I'm Lorraine. I run the Thyroid Trust. Hosting the meeting with me today, we have Judith Taylor, who's our Chair of Trustees, and who's kindly using the Zoom account of Thyroid Cancer Alliance, which she's also on the board of, to enable us to do this meeting. And of course, we have our wonderful speaker, who we're just so thrilled and grateful has given up his Saturday to speak to us today, Professor Atul Kalhan. Welcome, Atul, and thank you so much. I'm going to just start by saying a couple of housekeeping things. We are the Thyroid Trust. We're a new patient-led charity. We work very closely also with leading clinicians. We've only been established, we've only been registered with the Charity Commission since last May, but we've been doing events like this in London for quite a long time. And since we were offered funding to set up as the Thyroid Trust, we've also been doing a lot more awareness raising and advocacy work, and generally trying to scale up access to reliable information and good quality peer support for thyroid patients. So we're still at quite an early stage in our journey. I'm very happy to answer any questions that you might have about us, or sort of talk to you more about how you can get more involved if you'd like to afterwards. And yeah, that's us. We have a set of ground rules for our events, which we developed sort of way back at the outset when we started doing events in Hampstead at the Royal Free Hospital. And we just sort of like to ask everybody to sort of take these on board and ask if you've got any questions about them or if you've got any concerns about them, because I think these ground rules give us a nice, gentle, mutually supportive environment, which I think we all need. So remember that we're all patients here, apart from our speaker and our guests. Please be gentle in these meetings. Please feel free to say anything at all that you might want to say and to share anything at all that you might want to share. But obviously this isn't a forum for giving medical advice, and none of us are medically qualified, and those that are, a group environment is not an appropriate place to try and do that. And remember that we're all individuals. What works for one person might not work for somebody else. So, don't ever try and push solutions onto anybody else. And we try and allow everyone to have their say. It's a bit more difficult in the online space, but as much as possible, anything that you want to say, we'll try and give you a space to say any questions you've got. You can put questions in the chat, and we'll either come to you and unmute you and you can ask that, or I might read it out if time looks like it's getting a bit tricky. Is everybody comfortable with that as a way of running things and a sort of code of practice for behaviour? Anyone get any questions about the ground rules? Nothing coming in the chat, so we'll move on. Yeah, we'll aim to have a 5-minute comfort break at some point before midday. Atul says his talk is maybe 15-20 minutes or so there should be lots of time for discussion. I'm really mindful that the last couple of events we've had, there hasn't been a lot of time for people to ask questions and talk, because the talks are so interesting. I've got some announcements which I'll share just before the break. So without further ado, let me fully introduce Atul. He is a medical doctor. He is a fellow of the Royal College of Physicians. He's a very high-powered doctor. He's a consultant in diabetes and endocrinology at the Royal Glamorgan Hospital, and an honorary consultant endocrinologist at University Hospital of Wales in Cardiff. He's the course director on the PG Diploma and MSc in Endocrinology at the University of South Wales. He has won several prestigious prizes. He is editor of a key Oxford University Press textbook published in 2015 for specialist trainees. He's editor of the endocrinology section of a website that provides study resources for endocrinologists. He does lots of teaching and writing, as well as treating patients. He's widely published in peer-reviewed journals. So he's a really good catch for us today. And he's also a runner and a keen cricket and hockey player. So he's not just a doctor, he has real interests as well. So that's Atul. His talk today is entitled Lessons Learned from a Patient, Which a Book Cannot Teach. And he's specifically going to be sharing what he's learned from treating a patient who has a polyglandular autoimmune syndrome over 10 years. So I think we're all absolutely fascinated to hear that, Atul. Without further ado, I'll hand over to you.
It's an honor to be in front of such an audience. Thank you, Lorraine, because last few weeks have been something I've reflected upon And let me just move my slides. Yeah. One of the driving principles for my career has been a very simple statement. The eye see what the mind knows. And if you think about it, this statement holds good for all of us. We process information, everything is hinged into our subconscious, and we analyze it. And it's a very dynamic kind of process. As a clinician, all I've done for last 30 years, because I joined medical school in 1990, and I can't believe it's 2020 now, it seems like yesterday, is to gain as much knowledge as possible, so that if I'm confronted with something clinical, I'm able to analyze it and use my knowledge of whatever I've known for the benefit of my patient. So the I see what the mind knows has been one of the driving principles I've followed all these years. And now this concept is in fact more important in the current scenario. And I'll say that in all the domains, if we travel more and have a broadening of our vision, we learn more. One of the interests which I didn't mention in my brief biodata slide has been metaphysics. And if any of you are interested in metaphysics or have been reading about it, the whole process, the whole space-time as a fabric, it ceases to amaze me. It never, the vast universe around, the cosmos with no end. There are so many parallels to it. And if we look at things in a very microscopic way, we can go on to subatomic particles, to the quarks, and keep on wondering if it's a wave or an electron, right? And one thing I believe, that our universe, which is around us, is modulated by our own thinking, our own inner processes. So rather than spending too much time on these philosophical kind of musings, I'll move on to the next. All I want to say is that last 30 years of my career, there have been 3 phases. I probably will say from 1990 to 2000. I did my graduation and post-graduation from Delhi University. I worked, my first of the 2 MDs I did, it was on prevalence of thyroid dysfunction in patients with rheumatoid arthritis. And what I learned around that stage, there is so much of overlapping of symptoms. So a clinician who diagnoses one condition should not be oblivious of possibility of a second condition around. Second phase of my training probably involved coming to UK, doing membership exams, doing a second MD on neuroendocrine tumors. More importantly, it was a phase of personal growth, exposed to a different culture, different domain. I'm an adapted Welsh boy now, having been here for close to 2 decades. And then in between, getting enriched with clinical experience, which, all it has made me is more of a humble individual, because, going back to 90s, the famous song from UB40, the more I learn, more I see around, the more I learn. So without wasting more time, I'll move on to a real life patient I've looked after for last decade or so now, right? She's given me the permission to share her journey with you guys. And as I said, I probably want to say to begin with, this is a rare condition. It's not common, but there are so many things which we can all learn. And I wanted to share it with this group. So my patient, who was around 19-year-old in October 2006, autumn time, she was not feeling right. The complaints were very non-specific, included some kind of weight gain and cold intolerance. Gets a blood test done in the primary care. Her thyroid function is not normal. Her thyroid gland is underactive. Further tests are carried out and a diagnosis is made of primary autoimmune hypothyroidism. As I'm talking in front of an audience which comprises of members of the Thyroid Trust, I assume most of you will be well versed with the signs and symptoms of underactive thyroid gland, and I don't need to go into details of it. So around autumn of 2006, one condition, and started on thyroxine therapy. Everything goes fine for a few months, but next year, around summertime, she's still not feeling right. Symptoms were very non-specific. She complained of nausea, postural giddiness, lack of energy. The thyroid function tests were perfect. There was nothing wrong with it. The TSH, free T4, everything was within the normal range. So few more tests were carried out in the primary care, and I'm not going to go into the details of what initial tests were, and she was referred to the endocrine unit at Royal Glamorgan Hospital. The second condition, summer of 2007, which hit her age 20, was primary adrenal insufficiency. I'm more than happy to answer any questions later on, but to briefly sum up, these are the individuals who do not produce a key hormone, ACTH, and then end up not producing cortisol. So nausea, postural giddiness, low salt levels, lack of energy level. These are the symptoms which we commonly experience in this condition. So going forward, things were not getting right after a brief period of what seemed to be normalcy kind of. In 2010, she started to have increased thirst, increased micturition, increased frequency of urination. Further tests are carried out. And we know that she's got type 1 diabetes in addition. So we do say that diseases do not read books. I wish they could read books and behave in the way we want the diseases to behave, rather than flabbergasting the physicians. One thing which we are taught, that there is a compound known as urinary C-peptide, which in briefly saying is a marker of endogenous insulin production. We've been taught that we shouldn't be checking it for 5 years after initial diagnosis, but it disappears in 99.9% of the cases after 5 years. In our patient, 6 years down the line, she was still producing some insulin. So I wish the diseases read books and behave as the way they should behave, rather than going away from the statistical information we've got. So that was my first learning point, that, yep, although 99.9% of the time things should behave in a particular way, but yeah, if they are not behaving in a particular way, it doesn't mean diseases do not exist. October 2016, I still remember, my patient gets admitted with what we deem as Edisonian crisis. In a nutshell, what it means, you're not having enough steroids in the system, and it's a life-threatening emergency. She was on her medication, and these medication included hydrocortisone tablets and thyroxine tablets and her insulin. And, first question as a physician, as a clinician, you're trained to ask, is our patient taking a medication or not? And she was quite steadfast on it, and we believe what she was saying, that she was taking her medications as prescribed. So what was the reason that despite taking her hydrocortisone, she ended up with the steroid deficiency, which was almost life-threatening? So another lesson we learned, that although you may be taking your medications, there is a possibility you may not be absorbing the medication. And there is a condition which I'm sure many of you will be well versed with, celiac disease. When we investigated her by further test, she had celiac disease also. So despite taking the medication, she was not absorbing it, and she needed to go on a gluten-free diet also. We were saved around that time because we found another condition. So just to sum up so far, I'm going back to October 2016 now. My 19-year-old was growing 7 years down the line. She had fatigue, weight gain, thyroid was diagnosed, underactive thyroid, which was dealt with. A year later, adrenal gland go off. 2010, a diagnosis of diabetes is made. In 2016, she goes on to get celiac disease. Around that stage, I thought, probably the things are going to be better now, and we've started all these medications, we are giving her follow-up, everything will be fine. I wish that was the case, and it was beginning of 2018. So the story goes that around Christmas of 2017, she wasn't feeling well. Everybody thought she may be having a viral kind of illness, and luckily around that time, COVID-19 didn't exist. So there was a flu-like illness she had. She saw her GP, was prescribed a course of antibiotics also, drove to work, returned from work, sat down on a settee and collapsed altogether. And that probably was the thing which probably saved her in retrospective, because she was at home rather than having a collapse on the way from her workplace to her home, which was around 15 miles travel. She had a out of hospital cardiac arrest, needed DC cardioversion by the paramedics, was brought into the hospital in a peri-arrest state. So as I was saying, that the story which started in 2006, which I thought 2016, we were on top of it, took a new twist in 2018 beginning. And it was the moment I came to know, I was sitting in the clinic, and it was a shocker to me. Why did she collapse suddenly at home when we thought things are going smoothly? So she was not at all well when she was hospitalized. The blood pressure was low. She needed to be pumped in with lots of inotropes. Body temperature was low. She was unconscious. I'll not go into the details of her biochemical results, but if I have to sum it up, her kidney function had gone. Her TSH levels were sky high. Her electrolytes were low. So my next slide suggests what she was having around that time. She was extremely dehydrated, was in kidney failure, probably had an element of sepsis or infection. Her TSH levels were sky high around the time. And when we did a heart scan for her, the heart wasn't pumping properly. So she was in intensive care. And we thought the diagnosis at that stage is myxedema coma, which is an extreme form of underactive thyroid gland. In addition, adrenal crisis, which was more a clinical diagnosis. That means the steroids were not being pumped into the system. And we thought around that stage that, was she not taking a medication for last few months? Did the sepsis and infection contribute? Was she not able to absorb the medication? I'll discuss it in further details at the end of my slideshow. And on top of it, she had a stress response cardiomyopathy, and her heart function was severely impaired. So management aspect, she needed whatever we could throw at her. We gave her supportive therapy, hemofiltration, hydrocortisone, T3 therapy, and there were some management dilemmas which we were facing around that stage. We did worry about giving IV T3 therapy to her because we thought it may trigger rhythm disturbance. Her heart function ejection fraction was quite low. And we were worried about giving things through the NG tube. She was knocked unconscious because we worried about her absorption of medication through that route. So the choices were limited around that stage. And as a clinician, you've got limited time to make judgment around or decisions which can influence or change the course of life per se. So, and evidence to manage such patients in such extreme circumstances are very limited. Anyways, one more dictum around that stage which we follow is that thou shall not measure the TSH immediately, kind of. You wait for a few weeks for TSH levels to be measured, because the classical teaching says the TSH levels are slow to respond to a therapy. But we were adamant in monitoring her closely. So her TSH levels started to improve relatively rapidly, kind of, that within a week they normalized. And then there was a minor blip because we ran out of T3 therapy for a 24-48 hour duration, and then we switched her to T4 also. So that was my second learning point, that at times the TSH can vary or change much more rapidly than what is written in textbook. It's not something normal, but it was a exceptional circumstances. These were not normal. And now coming on to some better part of my presentation, not all the doom and gloom which I've talked about so far. Slowly and gradually, her heart function kept on improving. She was discharged home. There were lots of discussion with my cardiology colleagues around that stage. Should we put in a permanent pacing device? And, but at the end of it, we discharged her with her regaining relative health. So, as I said, this is an extreme example. This is not something very common. And when I was asked by Lorraine to speak about something which make me, in front of a patient audience, I thought I'll discuss this patient because there were so many learning points here. I'll spend next couple of minutes discussing about polyglandular autoimmune disease. And I've given you some statistics here about adrenal insufficiency being the most common aspect of it, with thyroid dysfunction also present in around 60 to 90%, and type 1 diabetes in around 20 to 50% of the patients. Let me reassure you, it's a relatively rare condition, with all three major components being present in less than 10% of patients labeled as APS type 2, and celiac disease only in 1 to 2%. So that made my patient extremely unique. Less than 2 per 100 million statistical probability of such a combination. So can lightning strike the same? This is just a lighter kind of slide, that 17 lightning strikes to Chicago skyscrapers in one evening. What you have to note, it struck the Trump Tower 8 times on the same day. So he's still there. I don't know if the lightning affected his cognitive function or not. I'll not say anything politically incorrect here. I'm coming to the very end of my slideshow. Our lives are very complex. We can have serial involvement of glands, which can have significant impact on quality of life. They can be issue with absorption of medication, compliance. And at the end of it, we ended up in my patient with a life-threatening crisis. So as a forum, I went through my case presentation and, I discussed with you, or I'm more than happy to take up any more detailed question about this patient or anything else which is relevant. But what I want the group to think about, and this is my time to hand it over to you guys, what could have been done to avoid this crisis? And one important point which I'll mention to you, when I asked her in retrospective, kind of when she had gone out of the hospital, she had recovered, what she mentioned to me was that it was getting very difficult for her to stick to a diabetic diet, to a gluten-free diet, and especially while she was working age 30 only. So she was in a full-time job. Whatever breaks she was getting were very limited. So she was working in an ice cream parlor and, very busy job in a busy part of city center. And at the end of the day, how she was managing her own life was much more complex than a clinician who sees her only at a single point of time can ever understand, right? She's mentioned that at times she felt like giving up because she felt life was unfair to her. Why she was the one who had to go through every single disorder. She found it very hard to explain it to her peers, her colleagues at workplace, why she wanted to take these breaks, why she wanted to carry her insulin injection. So there were lots of complexities which were under the surface. What, as a person, when you met her prior to this, everything hitting her, she came across as a very pleasant, happy girl who was getting along with all the conditions well. But what was lurking under the surface was the one which none of us could see. Her numbers few months prior to admission were fine. Biochemistry was fine. But the combination of factors altogether affected her compliance with the gluten-free diet, which affected absorption of the thyroxine tablets and the hydrocortisone tablet. And the little trigger which came in was the sepsis around, or the flu-like illness she had around Christmas time, and the explosive combination led to a life-threatening emergency. So if I can ask you guys, and this is something which we can ponder, we can discuss, what could have been done differently? Because as a clinician, I want to know how can I identify or red flag such individuals so we can provide them support. And as I said, there are learning points in here. Autoimmune diseases can cluster together. So if somebody's got one autoimmune condition, there is a theoretical possibility of individual to be prone to other autoimmune conditions. So both clinicians as well as the patient group need to be aware about these possibilities and have a low threshold to investigate, because some of the symptoms these autoimmune conditions carry are very non-specific. So symptoms of thyroid dysfunction can overlap with adrenal insufficiency. Celiac disease presents in a very non-specific manner. So keep our mind open. And that brings me to my first slide. Eyes will see what the mind knows. And last not the least, psychological as well as physical health influence our prognosis. So whatever way you may like to see it, from a holistic point of view, from metaphysics point of view, we shape our own universe around us. And these are the factors which need to be kept in mind when we evaluate somebody